Hey everybody, my name is Kim Griffiths. I'm a student physical therapist assistant at Jeff State, and today I will be talking about benign paroxysmal positional vertigo, or BPPV for short. BPPV is generally thought to be due to a collection of debris in the inner ear known as ear rocks or otoconia. And I accidentally put this fact in twice, and I did not mean to do that, so please disregard that. The utricle may have been damaged by a head injury, infection, or any other disorder of the inner ear. It can also occur because of degeneration due to advanced age. The most common causes of BPPV in people under the age of 50 is head injury, including indirect head injuries such as whiplash that you would experience in a car accident. Pathology continued of BPPV can also occur following surgery, including dental work. The cause is felt to be a combination of a prolonged period of supine positioning with vibration from drilling or after surgery to the inner ear. There is also a strong association of BPPV with migraines. Viruses affecting the inner ear, such as those that cause vestibular neuritis and Meniere's disease, are also significant causes of this disease. Gentamicin toxicity, while rarely encountered, can also be the cause of BPPV in people who have been treated with ototoxic medications such as gentamicin. Some statistics of BPPV. On average, about 1.6% of the population has BPPV, with 0.6% having begun that same year. BPPV is a common cause of dizziness and vertigo in patients. About 20% of all dizziness-related ailments seen in medical offices is due to this. About 50% of all dizziness in older people is also due to BPPV, and between 8 to 20% is due to head trauma, either direct or indirect, as I previously mentioned. Population affected by this can, BPPV can occur in children, but it's rare. It's more common in older adults, and the number of people affected increases linearly with age. The peak age of BPPV occurrence is roughly around the age of 60. This is due to a combination of the age risk of BPPV combined with a larger number of persons in the population at certain ages. Above the age of 60, 3.4% of the population has BPPV every year. Some symptoms of this include dizziness or vertigo, lightheadedness, imbalance, and nausea. Activities that bring on these symptoms vary between people, but symptoms are almost always present after a change of position of the head with respect to gravity. Getting out of bed or rolling over in bed are common problem motions that occur with BPPV. It's also sometimes called top shelf vertigo due to the symptoms of dizziness and unsteadiness that occur when people tip their heads back to look up. Women with BPPV may find that the use of shampoo bowls in beauty salons brings on symptoms, as well as certain yoga or Pilates positions. Diagnosis of BPPV. Physicians can often make this diagnosis based on patient history, physical examination, the results of vestibular and auditory tests. Another way to diagnose this is by way of the Dix-Hallpike test. And the way that this is performed is the person is brought from sitting to a supine position, as you can see pictured, with the head turned 45 degrees to one side and extended about 20 degrees backwards. A positive test result of the Dix-Hallpike would consist of a burst of nystagmus, which is jumping of the eyes. Physical therapy interventions for BPPV include the Epley maneuver, the CMOT maneuver, and vestibulo-ocular reflex training. The Epley maneuver includes sequential movement of the head into 4 positions, staying in each position for about 30 seconds. The CMOT maneuver is a procedure where the patient is rapidly moved from lying on one side to lying on the other. Both of these maneuvers, the way they work is they move these ear rocks or otoconia out of the part of the ear that it's affecting to a part that is less affected. So these maneuvers take about 15 minutes each to perform, and the end goal is to move these ear rocks that are present into a less affected part of the canal. So this is used to decrease the symptoms that occur with BPPV. ocular reflex training. It utilizes gaze stability, smooth pursuit, saccades, and convergence to help retrain the eyes. It also strengthens ocular muscles and reduces nystagmus. And I was going to talk about these 4 different methods of VOR training. Gaze stability includes one target, where a target such as this is something that we used at one of my clinical rotations, where there was just a card with a number on it, and you would hold the card about arm's length away from your face. And with gaze stability, you keep your eyes focused on the number while your head is turning. So you turn your head, but you keep your eyes trained on the target, which in this case, it's usually the number 1 or any number. For smooth pursuit with tracking, it would be, again, just one target, but your eyes are focused on the target and the target is moving. So this is something we would utilize a lot in clinic at my rotation, moving the card from side to side with the eyes remaining trained on the target. With saccades, you would have 2 targets and your eyes would shift from one target to the other while keeping your head still. So my eyes right now are shifting from the target 1 to target 2. And these are my 1 and the 2. I don't know if you can see them that well, but these are my targets that I'm using. So smooth pursuit would be shifting your eyes from target 1 to target 2 and back and forth. And this was something that was done in about 30-minute increments with a 30-minute rest, or I'm sorry, a 30-second rest. Let me backtrack. Done in 30-second increments with a 30-second rest break in between each one, and you would do this for 3 sets. And you would also do this to the beat of a metronome, and you could adjust the beat based on what the physical therapist found at evaluation, how well the patients are able to keep up with a certain beat of a metronome without any symptoms. If you're seeing symptoms, you want to back off when you perform this. And then the goal is to increase the beat of the metronome so that the patients can shift their eyes or move their head to a quicker beat to help better train those eyes. And the very last one is convergence, which is just something that is done with some beads on a string, and I don't have that to show you today. But basically what you do is just you move the beads as close to the patient as you can on the string. Patient's holding one end of the string here, therapist is holding at the other end, and you move the bead as close as you can until the patient has the bead out of focus, and then you move it back till it's back in focus, and you measure it, and that's the point of convergence. And the goal with that is to increase the distance or the point of convergence on the string. These are the 2 physical therapy interventions. The colored picture is the Bppv maneuver, and you can see where the patient is having their head rotated to various sides. And then the second picture is the CMOT maneuver. The patient starts out seated. They lay down towards the affected side. So in this case, the patient's laying on their right ear, which is affected. And then they go from that position all the way back over, laying completely on the other side. So those are just 2 of the physical therapy interventions, or another 2 of the physical therapy interventions used. Medical interventions, if the VOR training, Bppv maneuver, or CMOT maneuver do not prove effective in decreasing symptoms of this, a surgery known as posterior canal plugging may be recommended. What canal plugging is it blocks the most posterior canal function without affecting the functions of other canals. This procedure does pose a risk to hearing due to the breaking into the endolymphatic compartment while attempting to open the bony labyrinth with a drill, thus leading to this procedure rarely being used. Singular nerve section surgery is another alternative, but it also is not used because it's difficult to locate the singular nerve. And there wasn't much else I could find on that particular medical intervention. It just appears that neither of those 2 are utilized very often. But the physical therapy interventions that I previously mentioned, they have about an 80 to 90% success rate. So I believe these surgeries are just kind of a last-ditch effort, if nothing else, is solving the symptoms. But the physical therapy interventions do have a high success rate. And the reason that I chose to do Bppv as my topic is because at this clinical rotation, I had not yet learned about VOR training or any of the vestibulo-ocular training or anything related to that we did learn in our physical disabilities class. So I learned everything. I learned the majority of my information about VOR training at my clinical rotation, doing it hands-on, seeing it performed in front of me, and then applying it myself after I felt comfortable and familiar enough with it to be able to perform it on patients. So I thought it was really interesting. It was nice to learn something hands-on in the clinical that I had not heard about in any of my classes, and so it stuck out to me. And we also saw about 4 to 5 patients that needed VOR training a week. So this was also something really interesting. It's something that was used a lot with patients. So I went from learning about something completely new and utilizing it a lot, and that's why I wanted to share this with y'all. I hope y'all found it as interesting as I did, and I hope you enjoyed this presentation, and I look forward to any questions that you have. Thanks for listening.